And we are live. Good morning, everyone. Welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We have one item on our agenda today. And that is House Bill 123, the Preserve Telehealth Access Act of 2021. Been working on this bill for a number of sessions. And I first want to thank Lisa Simpson for spending a great deal of time over the weekend taking the feedback that you all gave us on Friday and producing the product that we're going to be looking at today. That was just a real yeoman's job that she was accomplished there. So I'm very grateful for it, getting it out to folks on Monday. I also appreciate everyone's feedback. I think that because of what you all have provided for us, this is going to be a better bill. And I'm hoping that we are very close, if not there, on this bill today. We're working from the document that folks, I think, received yesterday. And at the top, it's a reprint that's from 2/22/21 at 7:20 p.m. And my goal today is to not to go page by page, but rather to have folks raise issues or concerns that they have after having read it, based on the changes that we made from your comments on Friday. Lisa, do you want to go through the comments real quickly, and then we'll, or the changes real quickly, and then I'll open it up to the group.
Yep. Okay. So on page 3, we are striking subject to the limitations of the state budget. And that's page 3, lines 14. That was something that was done in House Bill 551. On page 4, there we are replacing the term practitioner with the term provider for consistency. On page 5, we're adding providers of long-term care services to the definition of healthcare provider. Let's see, on page 6 of the reprint, we're changing the definition of telehealth again. This time, the definition of telehealth will include for fiscal years 2022 and 2023 an audio-only telephone conversation between a healthcare provider and a patient that results in the delivery of a billable covered healthcare service. On page 7, the language is broadened to include all healthcare providers that appropriately deliver telehealth. Page 8 of the reprint, we're changing the definition of telehealth for the private insurance carriers. Let's see, page 9 of the reprint is removing some language in line 17, regardless of the location of the patient. The telehealth services are provided. That language is in 551, but because the language in 123 in the definition of telehealth, it's somewhat implicit that it's regardless of the location. It was causing some confusion. Let's see, on page 9, we're also specifying that a carrier may not require an insured patient to use telehealth instead of in-person services for behavioral health. And this was part of the language that was in subsection H of last week's reprint. And at page 9, it also clarifies that healthcare services appropriately through telehealth include counseling and treatment for substance use disorders and mental health conditions. Pages 11 and 12 of the reprint were striking sunset provisions that were from chapter 17 and 18 of 2020. This was something that Ellen Weber had brought up last week. This was kind of a drafting issue that we fixed. The top of page 13 specifies that the study language the study will include the use of remote patient monitoring for both somatic and behavioral health care. And then there were a few other changes to the study language that specify that the the study will include a survey of healthcare providers as defined in the bill, and that the Healthcare Commission will work with health occupations boards and other entities to send out the survey during the renewal process for those different boards and entities. And then at the bottom of page 13, top of 14 of the reprint, we're adding some legislative intent language.
Okay. So if you have a question, then I'd ask you to use the raise hand function and tell us which handwritten numbered page the question is about. I'll give folks.
Delegate Cullison, Kathleen Loughran, good morning.
Kathleen, who doesn't have his hand.
No, I'm just trying to use my real hand. I'm sorry.
Okay, I'll take it. Go ahead, Kathleen.
I don't know if Tricia Roddy or the department's on, so I don't mean to get ahead of them on this, but this was a discussion yesterday in the Senate, and I'm starting with page 3, lines 14 through 16. I just want to point out that everything in the Medicaid program is subject to the availability of funding in the budget. So I'm not sure why this language is being stricken. That applies to all benefits and all circumstances within Medicaid. It kicks off, I think, in the beginning of the Medicaid statute. So there are limitations based on state budget. I don't understand why this is being removed here unless the author or staff believes it's already applicable because it's stated elsewhere in the Medicaid statute. That's my first concern. The second concern I have on this page is at the bottom, and this really goes back to concerns I've raised in the past. There is a telehealth section in the Medicaid statute, There's no reason to cross-reference into the insurance article or cross-reference in the other direction from insurance article to Medicaid. It's been problematic over the years when this has happened in other sections of the code, and I think we should take this opportunity to continue to amend the Medicaid telehealth statute with its own language and not with a cross-reference back and forth from the insurance article.
Okay. All right. And did
Thank
you have
you.
anything else? That's it? Okay.
That's it on that page. Thank you.
Okay, so the answer to the first one, and Lisa, I'm gonna ask if you have another thought here. There was an assumption in line 14 that was a known fact, that we didn't need that in the legislation. So it was not saying that we presumed that there wasn't restrictions budgetarily, but that it is just part of the Medicaid program.
Okay, and that's what I thought, but I just wanted to be sure that I
Yeah.
understood that.
In the bottom of page 3, where we link the two, it's because what we've done in this bill is we have included both Medicaid and the commercial carriers. I understand your desire to amend the Medicaid program language. I'd ask that maybe we can do that next year, but for the purposes of this bill, we want to make sure that the same thing is true across both the program and the commercial carriers. So that's the rationale. Lisa, do you have any more on that? Okay.
No.
So
Oh.
I would just respectfully, I understand the need to make sure you're having mirror to mirror, and I'm not objecting to something in that section in the insurance article. I'm not objecting to having it in the Medicaid statute. But what I have found is going forward, when you come back a year or two later to try and make that type of correction, there's a lot of angst among many stakeholders because they think that you're trying to get out of having something apply to you. And because you passed legislation last March specific to Medicaid on telehealth, it seems to me that the construct is already there and that you just simply take these provisions, you lift them and you put them in the Medicaid statute. And then you can easily review to make sure you have an apples to apples. But it forces in the future people to amend Medicaid when they intend Medicaid and amend insurance article when they intend carriers.
Okay. Lisa, do you have a thought about that?
I don't. I think she's probably right that it should probably have been done that way. But this cross-reference was something that was already in there. It's being added, it's being actually repealed and added to the language again. I think in 2 years after the study is done, we're probably going to be doing fairly large rewrites of both sections. I'm just not sure that now is the time to do all of that.
Right.
That's, that's all I have on that.
What would be the impact of taking this out of this section? And putting it and making sure that it's in the insurance part.
So I'm not sure if that's a question for me or Lisa, so I don't want to overstep my bounds, but in my mind, there's no impact, there's no change to the application. I'm just saying whatever provisions are in 15-139 that you think should apply to both Medicaid or MCOs and carriers, take those very provisions word for word and put them under the Medicaid statute.
Mm-hmm.
So that you don't have to have this statement at the bottom of page 3 saying that the provisions in the insurance article apply to the MCOs.
And just Kathleen, just to be clear, the statement at the bottom of page 3 is what's being repealed. It is being put back in, but that is not where it's going.
It's gonna be put in
Right,
later.
no, I understand. No, and that's a good point because it's not this language in particular, but it's the same concept.
Right. Okay, I'm going to move to Ellen Weber.
Thank you, Delegate Cullison. This is a question on page 9, and it relates to the revision of C3 after line 20. This is now where the language that had been in subsection 8 has been moved up. And this is a question really to talk, I think, just a little bit about how this is going to be interpreted. Because this provision was obviously previously included with language that protected a consumer's choice to select the way in which health services are being delivered.
Mm-hmm.
Without that, I'm wondering whether we're losing some protections, because I don't know whether there's ever a situation where a carrier requires a patient to get services in a particular way. But in fact, if that's all that they offer, right, then that becomes the concern that we have. And so we were wanting to protect the patient's choice, the consumer's choice in how they're getting their healthcare services delivered. So I'm just really trying to ensure that we're not losing that protections by focusing just on what the carrier can or can't require. We appreciate this language. We want this language included. I just want to make sure that it's not going to be interpreted in a way that fails to meet that other concern.
I understand the concern. I guess my response is, as we were thinking about this, is we don't know yet how it's going to work vis-a-vis the carriers. And that's part of the reason we're having the study. And so I think everyone is going to be, during this 2-year period, one of the things we were convinced about was the behavioral health issue, and that that needed to be, particularly the audio only, had to be a part of that behavioral health. The rest of it, I think, is going to be a part of the study, and we're going to figure out how the carriers relate to providers and in how they develop their programs and products with respect to telehealth. And actually, Kim, do you have a response to that? Is that why your hand is up, or is that another issue? Kim Robinson.
It was actually up for another issue.
Do you want to speak to that issue for a moment?
I will at your request, Delegate Cullison. So I will say this, certainly my company, and to my knowledge, no one in Maryland's market is requiring anyone to prioritize telehealth over in-office visits. I think that there is some literature out there about some spaces where, for instance, large employers who are not subject to state law are developing programs for employees that are looking at making telehealth primary for primary care, for instance, where primary care is done through telehealth until your doctor says, well, but I need to see you, right? So that there are models, I think, that are actually already in place, not in the commercial market, not in a way that this bill would affect, and I don't think in Maryland, but where that's happening. And I think that there's a lot of literature that considers that a positive evolution of the use of telehealth in medicine and a better way to create access and appeal, particularly to like Gen Xers and millennials and Gen Zs, in terms of getting them into healthcare. So I do think that there's something to be studied to understand where that's happening, but my understanding is it's not happening in commercial spaces, and I don't think that that's a threat, and certainly something that the MIA will know because it would have to be filed in a policy. So if that were to, if somebody were to pop up, let's say in the next 4 months and file a product that was telehealth focused, the MIA can certainly let you know that, Delegate Cullison, if you'd let them know that it's something you're concerned about.
Okay, great. Thank you. Kim, I'll come back to you. I want to go to Delegate Krebs, who's on the committee.
Thank you, Madam Chair. And I'm just going back to what comments were made a little bit ago by Catherine. On all of these bills, I think it's helpful to have language each where you read it, unless it's redundant for a whole section, because it's easier to read. And so, does it belong in Medicaid? Does it take a little more time in the statute? Maybe it does, but I still think it's nice to be able to read something and understand what you're reading versus having to keep referring back on something that only takes a few words to add to it, another statute. So to the extent we can do it right to begin with, I think we should try to do that, because it's very difficult to follow these things for the average person, much less interpret back and forth. So I agree with her that we should be putting this in Medicaid statute, whether we should have stuff like subject to the limitation of the state budget. It says it later on in the bill, the limitation of the state budget to authorized by federal law. I don't really know what all sections it belongs with, but I don't have a problem with trying to make it self-explanatory to the extent possible. I think it's helpful. That's just my, and the other thing with the issue that we're talking about right now, with regard to the making sure that a person can get in person if they want. I just want to make sure we don't move in the direction that a provider only provides telemedicine, telemedicine and doesn't provide in person, because that can be problematic down the road too. And we want to make sure that people have a choice. So to the extent that that might be done in the study, that we don't want to do away with all in-person visits, because I think some people need that.
I would agree. And I think, as I said, that's going to be something I'm sure we will be looking at pretty intensely. Delegate, I wanted to clarify. So in terms of the language regarding the equity between Medicaid and the carriers, you're saying it should still be here, right?
I think it should at least be in the Medicaid statute. Having it here too just reaffirms what you're saying. I don't think to have it here, but it should be there too.
Okay. All right. So I'm going to go back to Kim Robinson, because you had another issue before I go to the next person. Kim?
Thank you, Delegate Cullison. And on the original topic, just for Delegate Krebs, again, this is not something that I'm personally involved with or my company is, but I will say from what I've read, even those places where somebody is trying it out, there still is always in-person care. So I think you're right that I don't think we'll ever be in a world where anybody could effectively sell a product where there was not also in-person care. I think it's just a question of sort of where someone starts, whether they're starting with telehealth or whether they're starting in office, is more the question of whether or not they're going to have access. So I think that's a really good point that you raised. My question, Delegate Cullison, was for Lisa. It was in section 2 I'm making sure I'm in the right place because the insurance article appears twice. I take that back. It's in section 1. It's the first appearance of the insurance article on page 8, I believe, page 8. What is line 32 and what continues. It has this reference to fiscal year, which is unusual for insurance because it makes sense for Medicaid because they operate on a fiscal year basis. And while I know it's reflecting the same essential timing of, ending June 30th, 2023, it's unusual language for the insurance article. It's sort of a sunset without being a sunset, right? Because it's exclusively.
Yes, that is exactly what it is.
Is that intentional instead of just writing it
Yes.
as a sunset? Okay.
Just to make it consistent with the Medicaid and the sunsets that, we could possibly move it. It's all about drafting. You can move it to maybe into the sunsetted provisions, but this was just for purposes of drafting it, what we ended up with at this time.
Okay. Yeah. The only reason I ask, I know that it's a little selfish. I'm going to spend a lot of time explaining what Maryland's fiscal year is because that's different for, different states. It's different than the feds. It's different than the company. So I know I'm going to get asked, well, what does that mean? Turn that into real dates for me because we don't talk in fiscal years on the carrier side.
Yeah.
Okay.
Thank you for your indulgence, Kim. I appreciate it. Delegate Saab.
Thank you, Madam Chairman. I'm not sure if it's even in the bill. I tried to quickly look at it. Does the patient have to have a bona fide relationship with the provider prior to the telephone call, or is it anyone can just call a doctor without having a previous, being a previous patient? I don't know if it's in the bill or not.
So it is not in the bill. The way the bill is written, that contact could go either way. I mean, an unknown doctor is not going to call a patient. So it would have originally been generated by a patient who is availing themselves of the service of a provider. So again, this is going to, remember, these are the kinds of questions we're going to need to be asking in the study. How does it work? who initiates? How is it implemented? So again, I'd ask your indulgence in allowing us to go forward with the way that it's here in the bill now, so that we can see where the initiation is best done. Does that make sense?
Yeah. I guess I'm just trying to figure out, because a lot of times,
Yes.
normally you'd want to have some sort of relationship with your behavioral health, for instance, or
Right.
not just like a stranger.
Right.
I don't know if there's, I understand what you're saying. I'm just trying to figure out if it's helpful to put some language in there to saying that they need to look, to study that as well, not just the initiation, but if there's a benefit. And I'm not a doctor, but I think if you talk to doctors or practitioners, they want to have some sort of relationship with their patients prior.
And I expect that, or I suspect, maybe not expect, suspect that's exactly what we'll learn.
Thank you.
That there is an established relationship. I'm going to go to Courtney Bergen.
Hi, yes. I just wanted to speak to Ms. Weber's point earlier regarding the provision about availability of providers, because I've actually had this experience in the private insurance market where I was offered access to a telehealth provider in lieu of a provider close to my home. So I think this happens not as an intentional thing where only telehealth services are offered, but when networks aren't adequate and there isn't a specialist in the area, I was offered a provider in Florida rather than access to an out-of-network provider that was 5 minutes away from my home. So I just want to give an example of how that can happen and just be so that we're cautious about it.
Right. No, I appreciate that. And you raise our concern that's in another area, but not in this bill, but it's one that we'll continue to work on. Kim, you had another comment?
I had a hand that didn't come down.
What?
Oh, okay, hand didn't come down. Okay. Ben, Stefan?
Tootie.
Oh,
So I wanted to respond to Delegate Saab. I think that that's an important,
you need that one?
and we are kind of looking at the pandemic as the framework for moving forward. And during the pandemic, is possible to see a physician without a prior relationship. I think the literature is mixed, but probably weighted towards it's best if telehealth is executed with a known provider. But I think that's, as Delegate Cullison said, at this stage, we leave it open and consider that as a question a study could give us guidance on.
Thank you, Ben. Jen Witten?
Yeah, thank you, Delegate Collison. And my response is actually to Delegate Saab as well. So just want to remind the committee that legislation passed last year that requires the health occupation boards to develop regulations as it relates to
Feels like
practice and standards. So, and there was also passed legislation focused on behavioral health services that has a number of provisions in terms of what's required when you encounter and work with the patient through telehealth. So just want to let folks know that nothing in this bill changes those requirements as it relates to clinical judgment, standard of practice. All of those standards have to be held regardless of what modality you deliver care.
Great. Thank you. Thanks for that clarification. Going to go to Lori Doyle.
Thanks. I was also going to comment on that particular issue, just to say that what we've seen with the use of telehealth as an initial visit, sometimes when people are hospitalized, particularly for behavioral health, if they are discharged without already a relationship in place, the no-show rate for that first appointment in the community is very, very high. So the ability to start that relationship via telehealth is important, and we've seen these no-show rates really drop. So it's a significant added access bonus for us.
Good news. Sorry. Delegate Karen Lewis Young.
Lori Doyle just made my point. But I will add to that, not only for mental health, is it very necessary to consider this concept of the first appointment, but also because of the coverage issue. You know, we know from so many years of previous hearings that we just don't have adequate coverage geographically, particularly in our more rural communities for mental health. So I just want to reinforce the point that we need to be very cognizant of that when addressing mental health.
Thank you, Delegate. I appreciate that. Ellen Weber.
Thank you, Delegate Cullison. I was just returning just to the point that Kim made in terms of the new information that she provided with regard to what is maybe being seen in some of the self-insured large employers in terms of really sort of directing certain populations to telehealth services. And my concern about that, obviously, is that it is, again, we know that network adequacy is being addressed in other ways, but this obviously, telehealth is also being considered very heavily for purposes of meeting those needs, as we've just heard from
Right.
And so part of my concern is, while we have this 2-year period, it is certainly a study period, but it is also a period in which we are trying to deliver good health services. And so I reiterate my concern that if all we have is being able to, some plans are putting in their plan documents to the MIA. And if all of a sudden consumers are having an experience where they don't really know what's happening, but they're now being offered telehealth visits, not in-person visits, that's something not only that affects the study, but it also affects the delivery of care. And I just am trying to figure out ways in which we can sort of protect the delivery of care while we're studying this issue, and not to lose that really critical component of how individuals get their services. So we also know that the carriers are the third-party administrators for these large employer plans. And so it's not something that just gets all of a sudden offered on an employer, on a self-insured plan. We see all of that filtering in, obviously. So I am just raising that really as a strong concern.
Right. And I hear that concern. I guess I'm gonna stick to my position, though, that I think we need to look at this. We're hearing from the carriers that they're not making those kinds of requirements. There's nothing on the horizon that says they're going to be those kinds of requirements. So, we need to have this time to really know what we need to take care of in terms of behavioral health and look at the rest. So I don't see any other hands. So Lisa, I need to ask you the question, can we vote on all of the amendments as a whole? Or do we have to vote each amendment independently?
Right now it's in reprint form anyway, so you're not seeing the amendments individually. If there's
Okay.
specific language that one of the members has a concern with, then that can be
Right. So
addressed.
let me
But-
ask, thank you, Lisa. Let me ask the committee. Is there any committee member who has a significant concern about any of the language in this reprint that would not get us to the goal that we want to achieve with telehealth? Okay, I am not seeing anyone. So would it be appropriate to make a motion to accept the reprint? Is that, I'm sorry, I don't know this process as well as I should. So what?
Well, I mean, it's just the amendments, your motion.
Okay, right,
amendments, and
okay.
that's-
So can I have a motion on the amendments?
I'd make a motion.
Do I have a second?
I'll second.
Okay. Is there discussion on the amendments?
Madam Chair, this is Kathleen again, and I don't mean to disrupt your process, but I thought we were going to go over each page and amendments, and I think we stopped after page 9. And I had a comment and concern on page 10.
Okay, so we'll count that as discussion of amendments. Go on page 10.
And this has to do with the payment of facility fees on a telehealth visit.
Right.
And I know you and staff have been very generous in looking at this and may or may not still be working on language. But the concern I have is that in the Medicaid program, if you allow for the payment of a facility fee for a telehealth service, you are in fact allowing the state of Maryland to be charged additional money for the provision of a service via telehealth rather than at the facility. And so while initially that may be a concern for an MCO, it will be incumbent upon the state of Maryland or MDH to build that back into the rates for an MCO. And it seems to me that the prudent policy here, particularly because there is a sunset and the facility fee is not being paid by Medicaid today, is to have a prohibition on the reimbursement of a facility fee under the Medicaid program. I can't speak to the commercial program, but for the Medicaid program, it seems to me you would not want to pay. What is happening today is that the HFCRC for the regulated entities are backfilling some of that money, not the Medicaid program. And then there are additional facilities not regulated by the HFCRC that would collect facility fee, including entities that are outside of Maryland, such as Children's Hospital.
Thank you, Kathleen. Let me ask you before I move, because I think Muncie may have an answer to this, or a better explanation. Right now, Medicaid does not pay facility fees?
Correct. They're not paying for it on a regulated entity because that is being backfilled by HSCRC, and I don't know all the mechanics of that.
And
But
is there a statutory prohibition at this point?
I don't believe there's a prohibition. I think
Okay.
that it was never provided for in the legislation you passed in March of 2020. And I don't believe it's provided for in the governor's emergency powers. I think this is something that the commission took on. And the problem is not only with facilities that are outside of HFCRC in Maryland, but you'll also have facilities outside of Maryland. And it seems to be fair across the board. There should be no facility fee paid by the Medicaid program, period.
Do we have somebody from HSCRC on the call?
You do, yes.
Okay, Megan, would you kind of address that issue for us?
Yeah, so last spring, HSCRC issued a memo that stated that clinic fees, which are facility fees in our regulated space, would not apply when providers could independently bill for that service that was provided through telehealth. But there are some cases of provider types who cannot or are not eligible to bill. And we do allow clinic fees in our regulated settings for telehealth when the providers cannot independently bill. And this is all described in the memo I submitted maybe a week and a half ago. If anyone wants more detail, that was shared last week. So our policy is a little more complicated. It's not that there are no facility fees. It's that if the provider can bill independently, there is no clinic fee. If the provider cannot bill, there is a clinic fee. But I do think Kathleen's point about the fact that HSCRC has, our zone of regulation is only so large, and there are facilities we do not regulate. And so, I can only speak to the policy for the facilities that we regulate. Yeah.
I think it's also important to note that in a conversation in the Senate yesterday, it was identified by the department that the current fiscal note on the bill does not anticipate the payment of facility fees. So that if you were to allow that in your legislation, that would change the impact of the fiscal note on the bill.
Okay. All right, so does anyone else have another section that is an issue? Monsi, did you want to speak to the?
Yeah,
Okay.
thank you. Thank you, Delegate. First I thought I did, then I thought I did it, but I do.
Right.
So I think just a couple of things I wanted to add on to the point that Megan made. Obviously that's why I think the language that you see in the bill is drafted the way it is, because the HSCRC does have the authority to set the policy in this space. I don't know how much we can even solve for beyond that in the Medicaid section. And I think that we have been, from the hospital standpoint, working with the Medicaid program on the different iterations of, who's within the HSCRC's purview and who's not. So I would say we've had a lot of those back and forth conversations, but the way the language is drafted right now in the bill really provides for the preservation of the HSCRC's authority to do really anything regulatorily in the space of facility fees. And we know that that was an area that we had talked about at some length and felt like this language really addressed that. So I wanted to just flag that from an overall standpoint. I appreciate the point on the fiscal note. I'm a little, I think, perplexed because we've this is how we've been operating, now till date. So I don't know that it would add anything new.
So I guess, and thank you for your comments. I guess my point here is, even if you believe this language preserves what's happening today, and I think as was explained to us, the HSCRC has tried to determine that in certain situations, they're building in payment for clinical fee. Medicaid is not paying that in any situation. And there's no language here that would say that the Medicaid program shall not be billed. If the HSCRC chooses to do what they're doing and they found a way to build in money for facilities in certain circumstances, that's different than requiring the Medicaid program to pay for it out of the Medicaid budget.
So in the spirit of, Ben, do you have a comment on this specifically? And you're on mute. Ben, you're on mute.
So on the issue of HFCRC's authority, I'm going to be silent about that. But I think what Kathleen is raising is a broader issue, and it's one that I would ask the committee to think about carefully.
Yeah.
Because it is an additional cost to the Medicaid program, regardless of how HSCRC approaches it, because facility fees are a feature of reimbursement that has always been thought of as important in face-to-face care, less so with telehealth. By example, in Medicare, under the program today, nationally, Medicare physician fee schedule payments are explicitly excluding the facility fee in most cases. So the parallel between what Medicaid is asking for and what's happening nationally, I think is one that's apparent to me.
I appreciate that, Ben. And I'm going to ask that we consider that this language simply maintains their authority. It does not increase facility fees. It doesn't change them in any way. And I suspect that if the HSCRC were to begin to increase the fees for Medicaid, but with facility fees, that would be something that we would be hearing about in our different reviews of the work of the HSCRCs. So I understand the anxiety that this might present, but I'm going to ask that we're trying to stay fairly close to the status quo at this point. In order to give us time to study it, this will be something that we can take a look at going forward in the study. So we have a motion on the amendments as presented. Any more discussion? Delegate Krebs, thought I saw your hand up.
Thank you. I took it down because I was listening to that prior discussion, which I think is very important. We have motions on the floor, and the amendments I agree with that we have. The question is, there were some suggestions on some clarifying language that would not change the content of what we're voting on. Can we ask that the clarifying language be put in the meantime, since it's not substantial, it's not policy. It's basically just.
Can I just add? Are you referring to the cross-reference that Kathleen brought up, Lochran brought up? Is that what you're?
Yes.
So I will just say, yes, I can go in and try to do that. It's not as simple though as just picking up language and dropping it in, just because some of this now, we had a pilot program in there that's now gone. We have a sunset that we're putting in this bill on some language that won't be in the other. I'm just saying I can do it and I will do it if that is the will of the committee, but it's not just adding a little bit of clarifying language, just so.
And listen, I appreciate the work that you have to do. I just think we should try to get it as right as possible, because it won't get changed for a couple more years. So
it's also going to make the bill 10 times harder to read. Just by the time I put all that in there.
Well, let's hope it makes it easier in the code to read it when the time comes in the statute. That's the goal, not just in the bill, but in the statute when you read it, that it's clear in the appropriate sections. That's all I'm asking. Thanks.
I'm going to ask Delegate Krebs, can you live with it the way that it is now, knowing that we know in 2 years that we're going to be having probably more than one bill that addresses telehealth, and we'll be able to separate out, we'll be able to address Medicaid separately from the commercials potentially?
Bonnie, when you asked something like that, how can I refuse? Certainly, but I would hope that it's this committee's intention to try to make these things easier to read in the places where for everything. And when the opportunity comes up, let's please drive for that. And believe me, I
Yeah.
know, Lisa, I don't know how you do what you do, but I just think it's worth it to get the things right in the right place as clear as possible when we can. So
Yeah.
commit to that in the future. I'm not going to argue with my wonderful subcommittee chair, but
Thank you.
I do agree with I definitely agree with the concept.
And I really appreciate your indulgence on this. And as long as it doesn't take away from the intent of the bill, I think, and I hear you about, making things as clear as possible. So we will endeavor to do that. But keep this language as it is. Seeing no further hands, then I'd like to vote on this, on the amendments. So all those in favor of the amendments, please say aye.
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 All those opposed, please use the raise hand function, and I will give you a minute. Delegate Krebs, your hand is up. Are you? There we go. Okay. Seeing no, the amendments pass unanimously. Can I have a motion on the bill as amended?
Motion.
Do I have a second?
Yeah.
Second. Bill's been moved and seconded. Any further discussion? Seeing none. Those in favor of the bill as amended, please say aye.
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 Those opposed, please put your raised hand in the participants box. Seeing none, the bill passes unanimously. You all deserve a great big hand. Thank you so much for your work on this. And I suspect we'll be talking with the Senate and, working out the I's and T's, crosses on the T's. But I think we have a great bill that will help move us forward in Maryland in the utilization of telehealth for the best benefit of our consumers. So with that, that finishes the work of the desk today. And the HGO hearing begins at 1:30 this afternoon. Thank you all very much.